Hello everyone, my name is Anthony Siler and I'm a sophomore biology major at West Virginia University, and my research study is on perioperative distress in office-based hand surgery. Now I'd like to talk a little bit about some background behind the study that we are doing. It's on office-based wide-awake hand surgery and has many benefits compared to traditional hospital-based surgery, which is done in the operating room. It's overall much more convenient. There's no pre-op testing, there's no need for changing clothes, there's no need for a driver. You can come in yourself and drive home the same day. And there's overall much easier scheduling. It has many cost benefits. There's overall much less resources needed. Less staff, it takes less time to do the procedure, and overall fewer supplies. It's a much more comfortable process. It's a quick needle stick with some numbing medicine versus a breathing tube, IV, EKG, post-op nausea, all the things that come with your traditional operating room procedure. Now here is some more background on the study that we are doing. Patient concerns regarding an unpleasant or stressful experience may prevent them from electing office-based hand surgery, because obviously this is a wide-awake surgery, so people are understandably going to be nervous and anxious and therefore maybe not want to pursue an option like this. So understanding patient experiences will help them to make informed decisions and to mitigate unfounded concerns about office-based hand surgery. And now this leads us on to our purpose, which we will be comparing patient distress expectation versus actual experience in office-based wide-awake hand surgery. So if we can find some variables that contribute to patient distress, we can hopefully mitigate that and identify good candidates for office-based hand surgery. Now this leads us on to our hypothesis. We predict that patient distress is going to start low, and then it will gradually increase up until the procedure date, and then it will drastically decline and go back to baseline post-operatively. So at first, we're predicting that patients are going to be nervous, understandably, about having a wide-awake procedure, but then after they have the procedure, it's going to drastically decline. Their stress levels will drastically decline back to baseline post-operatively. Now this leads us on to our methodology, which is how we will get our results. We're going to be using something called the Subjective Units of Distress and Disturbance Scale, also known as Suds. And what it is, it's a 0 to 10 scale used for evaluating anxiety. And this will be applied to several sources of distress, such as awareness, needle sticks, surgical pain, discomfort, and outcome. And basically, patients will rate these different categories from 0 to 10 based on how distressed they are at multiple time points. And we'll also be using the Amsterdam Preoperative Anxiety and Information Scale. And this is a 6-item questionnaire that measures anxiety of specifically anesthesia and surgical procedures. And this is only done 2 times preoperatively. So this is before they have their procedure. It is not done postoperatively at all. And higher numbers will indicate a higher stress level on a scale of 1 to 5 for each APAIS item. Now we're going to be using questionnaires to assess patients' distress levels at these multiple time points. And these patients are going to be undergoing specifically the Wallant procedure, which is a specific type of office-based hand surgery. And the inclusion criteria are adult patients who are scheduled for office-based hand surgery, this procedure, who will consent to participate in this study. And the exclusion criteria are people who have had current or recent severe psychologic or psychiatric condition, including substance dependence. And these people who qualify for this they did not even have the procedure at all. So they're obviously not included in our study. Now here I'm going to discuss our data collection process, so how we will be getting our data. So as you can see, we'll be doing surveys at 4 different time points. So 1 week prior to surgery, right before surgery, 24 hours before surgery, within 2 hours following the surgery, so this is immediately after their procedure, and then 2 weeks following the surgery, which will be our follow-up. And we'll be using descriptive statistical analysis and repeated analysis of variance tests to kind of see our trends and be able to measure the results that we get. So here I'm going to talk about some descriptive statistics that we have measured from our patients and that are undergoing office-based hand surgery. So we found that all of our patients completed the immediate post-op, and 78.9% completed all of the surveys all the way through the 2-week post-op survey. We see that 52.6% of our patients had surgery done on their right hand. We see that the average age was about 56, 57 years old. 63.2% of our patients were female. And as you can see, through the surgeons, it was pretty evenly distributed over the 4 surgeons and the patients that they each had for this study. And the average time of the procedure was about 16 to 17 minutes. And 31.6% of our patients qualified for depression, and 22.8% had anxiety. Now here are some more descriptive statistics about our patients that are enrolled in office-based hand surgery. You can see that the top 2 procedures were carpal tunnel release and trigger finger release, with 42.1% and 31.6%. About 28% of them, their procedures were done using a tourniquet. About 51% had a prior history of awake surgery, and 21.1% had prior history of a wide awake hand surgery, and about 91% had prior history of just general anesthesia, so any basic operating room procedure. Now here are our results that we found from the APAIS survey. So as you can see, this was done only at 2 different time points, both preoperatively. So the 1 week prior to surgery and right before surgery. And as you can see, these are only questions about anesthesia and about surgery in general. And these questions where you see no anesthesia, mind anesthesia, worry anesthesia, we ask them questions that are something like, the anesthetic is on my mind continually, and they rate that from 1 to 5. I would like to know as much as possible about the anesthetic. And how worried are you about the anesthesia? So they rated this on a scale of 1 to 5, and as you can see, that people were fairly comfortable. They averaged out at about 2, and it did not go up before surgery, right before surgery. So the difference between immediate pre-op and the pre-op was about the same. So they're comfortable with their understanding of anesthesia and their understanding of surgery. Now in the next few slides, I'll be discussing some of the results from the Suds surveys amongst the various variables. And as you can see, we did this for 4 different time points, and this specifically is looking at surgery in general. So we asked the patient, on this scale, how do you rate yourself regarding surgery in general at this moment? And it was rated from 1 to 5. And as you can see, from the preoperative to the immediate preoperative phase, so right up until surgery, there was a little bit of an increase. And then postoperatively, there was a drastic decline, and it continued to decrease 2 weeks postoperatively. So this was not nearly what the patient thought it would be, and it was much less minimally invasive. Now here we asked the patient, how do you rate yourself regarding pain during the surgery at this moment? So how distressed they are, or how concerned they are about the pain. And as you can see, there was a similar trend to the last one. There was a slight increase up until right before surgery, then a drastic decline, and then it continued to decline 2 weeks postoperatively. Now here we asked the patient, how do you rate yourself regarding the physical discomfort during your surgery at this moment? Since, they will be in a chair and they will be awake during the procedure, so this is just a measurement of physically how comfortable they are throughout the whole procedure. And as you can see, it's a very similar trend than before. It increases up until surgery, and then there was a drastic decline postoperatively, and it continued to decline postoperatively. So this was another overprediction of distress. Now here we ask the patient, how do you rate yourself regarding the needle sticks needed for your surgery at this moment? And as you can see, it stayed about the same from the preoperative phase up until the surgery, and there was a drastic decline postoperatively right after. But this shows a more interesting trend. After the 2-week postoperative phase, patients seemed to reconsider what they thought originally, and it made a drastic jump back up. So this seems to be a point of distress for patients. Here we ask the patient how concerned they are about being wide awake during the surgery. And as you can see, from the preoperative to the immediate preoperative phase, there wasn't much of a change, actually a slight decline. And then post-operatively, there's a drastic decline once they realized that it was not as bad as they thought. And that stayed about the same through the 2-week post-operative phase. Here we ask the patient how concerned are they about the success of their surgery, how much it was going to help them. And as you can see, their distress levels went up significantly, actually, from the preoperative to the immediate preoperative phase. After they had it done, they weren't too concerned, but 2 weeks post-operatively, maybe when they tested it out and when it was healed up some more, 2 weeks post-operatively, you can see it jumped up a little bit, so they still were a little bit concerned about how much that is actually going to help them. Here we are going to look at the effects of potential confounding variables. So all these variables, we're going to see if they had any impact on our results of Suds or the APAIS measurement. And so we did a subgroup analysis based on these variables to see if these impacted our results. Now here we can see that anxiety had a significant effect on multiple Suds, multiple surveys during different time periods here. So as you can see, anxiety is a big factor in their rating of distress levels. Here we can see, along with anxiety, that depression had a significant effect on our results, specifically during the Suds test and at the various time points, the immediate preoperative and immediate postoperative phases in particular. Here we see some more variables that contributed to a different result than we expected, and this was the history of awake hand surgery and also sex. So as you can see, and this affected our Suds test at the different couple different time points, and specifically this was in the domain of success when we were asking them to rate how concerned they are about the success of their surgery. Here also age contributed to a different prediction during the Suds tests that we had, specifically in these domains about how worried they are about the success of their procedure, how worried they are about the anesthesia, and how concerned they are about the pain during their surgery during these several tests that we ran. Here we see those that had prior distress during general anesthesia. They also seem to have a significant impact on our results, specifically when asked about the variables in the Suds test, and this only occurred during the 2-week postoperative phase, we noticed. So because we ran so many tests, we ran into a multiple comparison problem. And what this is basically using a p-value of 0.05 means that we accept 5% of error, basically false positive findings. And we tested a total of 324 combinations, so that means we were accepting about 16 erroneously positive findings. So that's basically means that they are incorrect. And now we use this Bonferroni correction that fixes that by lowering the p-value cutoff to 0.00015. And when we do this, none of our findings are significant. None of the variables that we measured and looked at are significant. But when we lower it to approximately 0.01, we have 3 variables that remain significant. And these are that anxiety affects the pain variable in Suds. When we asked about, we made them measure their how distressed they are about specifically pain during surgery. And then sex affects the success variable in Suds. So how concerned are they about the success of their surgery? And then general anesthesia distress affected the 2-week awake variable in Suds. So how concerned are they about being awake during surgery? Now this leads to our discussion, and I'm going to conclude some of the results that we found from this study. So there was a statistically significant distress progression that we noticed through all these figures and charts from baseline up until the day of surgery, and then a significant drop immediately afterwards. So patients' distress expectations did not materialize. It was not nearly what they thought it was. It was not nearly as bad. And patients were mostly concerned, we found, about the needle sticks and the post-op pain. The worst part was the needle sticks as shown in the post-op results, but it was not nearly as bad as their preoperative expectations. And finally, some implications drawn from our study. Our results will help surgeons to educate their patients about actual office-based hand surgery experiences, and it will help to improve the overall patient experience. It will also help to develop tools to screen and mitigate perioperative distress in office-based hand surgery, and allow us to identify good candidates for the surgery while increasing success post-operatively with less distress levels. So in conclusion, the patient experience of distress was half what they thought it would be originally. And this will conclude my presentation. Please feel free to contact me if you have any comments or questions at my email, or leave a comment below. And I thank you very much for your time listening. And other than that, I'd like to take this time to thank my mentor, Dr. Shafic Sraj, for giving me the opportunity to work with him and gain the experience and education I have so far.